matter what I do, I'm stuck on you. I got deja vu. Yeah, I got deja vu. Yeah, I got deja vu. Yeah, no matter what I do, I'm stuck on you. I got deja vu. Yeah, I got deja vu. Yeah, I got deja vu. I got deja. I got deja vu, yeah, I got deja vu, yeah, I got deja vu, yeah, no matter what I do, I'm stuck on you. I got deja vu, yeah, I got deja vu, yeah, I got deja vu, I got deja. Stay high, can't lie, I just gotta keep you up in my mind, I just gotta stay.
Hello and welcome to our discussion on the COVID-19 pandemic. I'm Dr. Tim Beagley, Professor of Biology. Joining me today is our Biology Laboratory Manager, Annette Shelton. Annette did her graduate work at University of St. Joseph in Connecticut and is an absolute expert on all things microbiology. Welcome, Annette.
Thank you. Glad to be here. I'm glad that we're able to do this.
Awesome. Also in the background joining us is our producer, Thomas Winkley. Tom is running the show for us, and we simply can't thank him enough. Tom, thank you.
Yes, thank you.
So even though the pandemic is not yet over, it is subsiding, and we certainly hope that continues. In addition to heavily impacting all of us, the COVID-19 pandemic has basically laid the groundwork for the next 30 or 40 years in epidemiology and virology research. Scientists will now turn their attention to questions of how it happened, why it was the way that it was, and if things could have been done differently. It is very early in the process, but we would like to share some of the kinds of questions that people will be asking. To help us do this today, we have a special guest, Dr. Nathaniel Lewis. Dr. Lewis has a PhD in medical geography, which is basically the study of patterns in health risks and outcomes across places and populations. After working as a professor at the University of Nottingham and the University of Southampton in the United Kingdom, he joined the Epidemic Intelligence Service for the Center for Disease Control and Prevention. As the field officer for Utah, Dr. Lewis led the Utah Department of Health investigation into vaping-related lung injuries in 2019. And in 2020, of course, he has led the CDC investigations into household and school COVID-19 transmission here in Utah. Dr. Lewis, welcome.
Thank you so much for the introduction, Tim, and for the opportunity to present some of this work that I've done on COVID-19 as an officer in the Epidemic Intelligence Service, or EIS. Tell you a little bit about EIS. EIS is a program that places a collection of medical doctors, veterinarians, nurses, and PhD scientists like myself into posts at either CDC headquarters or at state and local health departments, which are colored here in blue. Your job as an EIS officer is really to respond to and investigate any pressing health issue faced by the jurisdiction that you're working in during your 2 years there. So in the past, this might have been E. coli outbreaks at state fairs or salmonella outbreaks at family potlucks. But in the class of 2019, which is my class of BIS, we have been dealing with the much bigger pandemic of COVID-19. So I want to share with you investigations that the CDC has done in Utah, especially our first big investigation that we did here on transmission of COVID-19 in households, and then also give you some snippets of other work that we've done on both neighborhoods more generally, and then most recently on elementary schools in one school district within the Salt Lake Valley. So this graph gives you an idea of when each investigation took place. So households for a couple of months near the beginning of the pandemic, as it was experienced in Utah, neighborhood investigation using data for sort of the first half of 2020 altogether. And then elementary schools, as I said, most recently, is to sort of right at the end of 2020 and at the beginning of 2021. So sort of spanning before and after the holiday season. I want to start with our household transmission investigation, and specifically kind of a sub-investigation within the larger investigation that I led. So when this work began in March 2020, we knew based on estimates from Asian countries and work on so-called family event outbreaks that the household was likely an important site of COVID-19 transmission, We also knew that some transmission was likely occurring from pre-symptomatic or even asymptomatic individuals. So pre-symptomatic meaning they do eventually develop symptoms, but they're transmitting it to other people before those symptoms show up. Asymptomatic meaning that they never have any symptoms at all during the course of their illness. So our first order of business was to try to get a reliable estimate of secondary household transmission in a U.S. context. So once somebody in the house has it, how many other people in the household, as a proportion of all individuals in that household, are likely to get it. But secondarily, and this was decided about halfway through the main investigation, was that the household would also be a good site to study the timing and characteristics of when initial viral shedding begins in a newly infected person. In other words, how soon after they're exposed do they test positive, and to what degree does the onset of shedding coincide with symptoms or their potential infectiousness to other people? And we would use a viral culture to kind of estimate the likelihood of this infectiousness. So our normal process for recruiting households into the main study was to wait for nurses at the county health department, take on cases coming in through the Utah Electronic Disease Surveillance System, or EpiTrax. The nurses would complete their investigations and then refer them to us to see if they met our criteria for being a household within the study. So for that, there would need to be an index case, so the first person to get COVID-19 in the house, and then at least 2 additional presumably uninfected household members, with the index case being less than 10 days from their original diagnosis. We would then go ahead and call the household for enrollment, and to really capture initiation of shedding as it happens, we needed an accelerated recruitment protocol. So we needed to find households almost immediately after an index case in a household was detected and uploaded into EpiTrax. So for these 5 households, I generally scanned the surveillance system myself every morning, got permission from the nurses to contact these houses directly and try to enroll them in our study. So within about a week, we found 5 households to participate in this intensive study, which is what we called it, with index cases enrolled a median 4 days after symptom onset in an index case, and a median of 3 additional household contacts within that household. So a contact meaning a presumably non-infected person who is also living in the house. So once agreeing to enroll, all households had pre-enrollment interviews to assess their symptoms and exposures to the index case. as well as a household questionnaire to assess the household environment and mitigation measures that that household might have undertaken. So after we did the interviews, next all household members received a nasopharyngeal swab at their first visit. And during a final visit 14 days after that first visit, contacts to the index case were also swabbed every day for 4 days after the first visit. And all household members also completed a symptom diary for 15 days. So these specimens were tested by RT-PCR, which is reverse transcriptase polymerase chain reaction at Utah Public Health Laboratory. And any newly positive specimens detected on days 1, 2, 3, or 4 were also sent to CDC for viral culture. So in 3 of these 5 households, they isolated the index case as soon as that household was able to tell that the index case was sick. And this is denoted by a blue X. So usually shortly after symptom onset, they put the person in a separate room. In one instance, they actually put the sick index case in a separate trailer outside of the house. I felt bad for that guy, but that was, probably the safest thing to do. In the other 2 houses, the index case stayed confined to a separate bedroom, and in one of 2, they were able to use a separate bathroom as well, and the other one they were not. But I think what's important to note is that none of these 3 households experienced any secondary transmission, as indicated by only negative tests outside of the index case. So in another 2 households that implemented no precautionary measures, generally for childcare reasons, it's a family where there's young kids, mom and dad essentially, need to do daily activities involved in childcare, feeding, dressing, walking to school, anything that normally happens within a household. In these households where they did not make any isolation decisions or undertake any precautionary practices, everybody ended up getting COVID-19. So developed in these households, everybody basically essentially became affected with COVID-19. I'm going to zone in a little bit more on these 2 households that I've outlined here in red. So contacts in these 2 households experienced onset. So symptom onset indicated by a green explosion symbol here between 2 and 5 days after being exposed to the index case. So generally a median of 4 days after being exposed, those contacts became sick themselves. This is a little bit shorter than has been observed elsewhere, but it's kind of unsurprising given that there was exposure pretty much immediately to the index case once that index case was able to transmit infection. You're living together, you're in the same space, you're in the same rooms, you're probably having close contact, sitting on the couch together, eating meals together, etc. So this interval of 4 days is not super surprising. In 2 cases, the first positive test occurred before the onset of symptoms. So this provided a granular confirmation that yes, pre-symptomatic shedding exists. You can infect other people before you have any symptoms. In one of these 2 cases, we saw a substantial drop in CT values, indicating higher potential infectiousness right after her symptoms began, and then a further drop again with the appearance of new symptoms. In another, we saw consistently moderate CT values and mild symptoms for only 2 days. So this gives you an idea of kind of like the range of illness that can occur in different people. Sometimes it is very short-lived and has very mild symptoms. In others, it's a pretty linear progression from, not too bad to worse and worse, and that, their infectiousness toward other people can tend to coincide, with the progression of symptoms getting worse and worse. Not always, but in this case, yes. So in an additional 2 cases, the first positive test occurred on the third household visit. So that means that we were able to basically detect the onset of COVID-19 or the onset of viral shedding, even if not necessarily symptoms, in real time. And so these occurred 1 to 3 days after the onset of symptoms in those patients. In one of these two cases, we again saw a very short duration of illness in a female child who only tested positive on days 2 and 3. But this time we were able to verify that live virus could be cultured. So again, very short duration, mild illness. We were able to culture her virus, indicating that she would have been able to infect other people. And this happened immediately before the day on which she reported the most symptoms. In the second case, we observed a potentially longer span of illness and 2 positive viral cultures that coincided with low CT values. So CT value it's kind of a way of detecting, viral load or concentration of the virus in that person. And so we were interested in, seeing the degree to which that coincides with symptoms. And we found that, sort of often it does, or most likely it does, though not always. So sum up the household investigation, I really take the findings from these cases. I kind of put the findings in 2 groups. One is essentially a call for substantial precaution. We were able to verify that pre-symptomatic transmission exists. And in children specifically, we saw really short-term mild illness, but one of which still produced a positive viral culture. So the illness can be super mild, you can still infect other people. However, what we also saw, and I think this is encouraging, is that households that even made an attempt to isolate the index case did not experience any transmission to other people, even after symptoms appeared in the index case. And this is validated by our case-to-case data, which seems to suggest that the peak of infectiousness occurs a day or so after symptoms begin, at least when there are observed symptoms. We also wanted to look at disparities in COVID-19 infection more broadly, and I know Professor Beagley is going to talk a little bit more about that. So we wanted to look at differences in infection rates across Utah's neighborhoods and communities, and the extent to which this varied, based on how socioeconomically advantaged or disadvantaged those different areas might be. And so, you might be asking, why? Why do we want to look at that? What is it about socioeconomic disadvantage that would make you more likely to get COVID-19? Well, what we found is that in very high deprivation areas compared with very low, so like I said, it's a measure of socioeconomic disadvantage. We found that in those areas, 36% of people are working in essential occupations versus 18% in the most economically advantaged areas. 7% are living in dwellings with more than 1 person per room, which basically is a metric of, crowdedness. 23% were Hispanic or Latino versus a much lower percentage in advantaged areas, and 22% were non-white. And we found that during that time period in these kind of, more socioeconomically disadvantaged areas, the odds of SARS-CoV-2 infection was 3 times higher than in low deprivation areas. So, it's not just a matter of looking at that overall, what we call an epi curve of how many cases are there in Utah at any given point in time, but also what are the differences, between different areas of Utah. Are some areas much more affected than other areas? And then finally, I just wanted to touch on, the question of school, because later in the pandemic, a new question came up in Utah. Schools here were staying open despite a very high rate of community transmission in Utah, which was not necessarily the decision that other states were making at that point in time. So this allowed Utah to sort of be a living laboratory to see whether schools elsewhere could be open safely. So in this investigation from this past winter, essentially what we found was there were only 12 new infections among 728 individuals who were exposed to an index case of COVID-19 at school. And furthermore, we found that only 5 were likely to have actually been infected at school. with the remaining 7 having some sort of other epidemiological link to a different exposure event, usually being exposed to a sick family member or a sick person at their home. So this further kind of reinforces that, like, yeah, household is really kind of like, it's incidentally where people put their guard down, but it's, where they should really have their guard up, because that's where they're likely to be contracting it. And furthermore, what we were able to find from this investigation was that elementary schools in the Salt Lake County School District, where we did the research, had these very low rates of transmission, even when they were not able to follow CDC guidance of keeping students, 6 feet apart, which was what was being recommended at the time. So it was partially based on this study that CDC revised its guidelines that students can, ideally should be at least 3 feet apart, but if they're able to maintain that while keeping on their masks, while keeping up sanitation procedures, school, at least elementary schools, are not places that pose severe risk of COVID-19 transmission. So I hope that gives you, kind of a quick overview of 3 different sites where COVID transmission happens in Utah. And I know Professor Beagley has some questions for you all, and I'm happy to answer any questions later in the session. Thanks.
Thank you very much. That is absolutely fascinating and critical work. Annette, do you have any comments at this point?
Nope, not at this point.
What we're going to do now, after that nice introduction, is to look at some examples of the kinds of questions that epidemiologists will be asking over the next many years as we sort of perform our retrospective analysis of what the COVID-19 pandemic has done. And it's very early in the process, so please just be aware that these questions are at very high level. It's like we're flying at 40,000 feet right now. And even though Dr. Lewis's analysis were really ground level analysis, some of the major questions that are starting to be asked right now are really at a very high level. So we'll entertain now a couple of questions and talk about them. And then if you are on the Twitch feed, don't forget you can send your questions into the chat there. And our producer, Tom, is gathering them together. We'll answer some of those questions after we talk about these 3 main questions. Okay, so Tom, if you could show me the first question, please.
You're up, sir. So that's the pandemic worse in the USA than other countries, right?
Okay.
It is
so
live.
one question that we could possibly ask, and it seems to be on a lot of people's minds, was the pandemic worse in the United States than it was in other countries? And if so, maybe why? So let me just sort of frame that question with some early statistics for you. Tom, if you could show me the second slide, please. So this slide shows some data from different sources that show the United States of America has about 4% of the world's population. And yet, according to the Johns Hopkins COVID tracking website, we actually had about 24% of the world's COVID-19 cases and 20% of the world's deaths from COVID-19. So on the surface, at least, and again, this is very early in the analysis, it appears that the thing was worse in the United States than the world at large. And then you can see the mortality rate above 4 times what it was throughout the rest of the world. So a couple of things to consider here. Tom, will you show me the next slide, please? One thing that people could argue is that maybe the United States overreported. And I think the argument against that can be seen pretty clearly in the chart of what is called excess deaths. So the CDC monitors on a fairly constant basis the number of people in the United States who have died from any cause at all. And you can see here, it's a fairly constant thing. That gold line across there, that pattern is pretty consistent from one year to the next. But you can also see that over the last couple of years, 2 things happened. First of all, in January of 2018, there was a small epidemic of influenza. You can see the spike that happened there. But if you look at the far right, you can see what we refer to as excess deaths. And this is a very large number of deaths above the expected level. And this is basically a reflection of the pandemic. By the way, the excess deaths is more than the count, which is now approaching 600,000. So according to this particular analysis, it seems possible that if anything, we've underreported the number of deaths, especially early in the pandemic. Next slide, Tom. Another thing that people could argue is, well, we weren't the worst, and we weren't the worst in terms of the mortality rate. So you can see the United States here with 160 some odd deaths per 100,000, but there were some countries who had higher mortality rates. You can see the UK there as well. But there's lots of countries that had lower mortality rates, and some of them undoubtedly underreported. I mean, you've got places that typically and historically haven't wanted to be shown in a bad light, and so they have had a history of underreporting. But you also have countries here like Germany and Switzerland. These are pretty advanced countries that, for all we know, they are accurately reporting the mortality rates. So one question is, are there structural things in the United States that made the pandemic worse here? Maybe not necessarily worse than the rest of the world, but worse than it really needed to be or should have been. So I'll pose that question to Dr. Lewis and to Annette.
I can, I mean, I can start and answering in like as diplomatically of a way as possible. But I think two things to consider are, I guess, the level of the quality of the healthcare system, which, although this access to those systems will vary across different subsets of the population within the U.S., the overall development of the healthcare system, I think, is what owes to having a lower mortality rate despite a pretty high infection rate. So the
case fatality rate is lower than the rest of the world. And so even though we had more cases, according to that analysis, we had fewer deaths than would have been expected. Yeah, I see what you're saying.
Yeah, and I mean, as far as there's so many things that go into an incidence rate, and why you see differences across countries. But there's challenges in the U.S. as far as consistency across jurisdictions, and here we have a situation where sub-federal jurisdictions, so different states can do different things, and unfortunately, people are mobile and they don't just stay in one jurisdiction. So there's we have to question the degree to which consistency or inconsistency across jurisdictions affects a federal level response or reaction to a pandemic like this.
So that's an important point, because that means there's something we can do about that, right? There are ways that we can more standardize that response and sort of bring everybody onto the same page.
And certainly while people can make their own decisions about how to protect themselves, we know that public health is it's kind of a group exercise to some extent. So we're relying on policies and guidelines to inform the changes that individuals make and inform the degree to which people are doing it consistently across different jurisdictions.
Annette, did you have something to add there?
No, not that I could think of. I was just thinking of the consistency, and I was kind of curious in terms of timeline as well, and response time, and how that fed into it.
Well, looking back at the beginning of the pandemic, it seemed like it took forever to get testing in place, and and you had different people doing different testing. So I think this whole point of discombobulation, if I can use that word, seems to have really shown itself at least early in the pandemic. So I think that's a great point for us to focus on policy-wise. Okay, Annette, do you want to take the second question for us?
Yes, so the next question 2, that we can look at is, in terms of deaths, why is it that there were many Americans that died in long-term care facilities? And so with long-term care facilities, we're referring to nursing homes, skilled nursing facilities, assisted living centers, and then other types of care facilities. And so there's some statistics that said, that around 182,000 residents and staff has succumbed to COVID-19 as associated with long-term care facilities. And so with this next slide, it actually shows a little bit more in terms of percentages. So while around 1% of the American population lives in long-term care facilities, around 34% of the US COVID deaths are associated with long-term care facilities. And so the percent of deaths that we see by state, this graph kind of shows by state across, with New Hampshire over on the left with 69%, and then Alaska with 2%, and Utah right there somewhat in the middle around 33%. And so, what is this reasoning in terms of 1% of the population, yet 34% are succumbing to this disease? And of course, in looking at long-term care facilities, there are a couple of things that we can focus in on. And one of the main things that we can focus in on, of course, is the age. So we can see how age plays a role in terms of that. And so this is what the next slide, kind of the age factor. So with the age factor, if we look at the percentage of total deaths, you can see with this graph here, right around 50 years old, the percentage goes up in terms of the total deaths. It's estimated around 98% of deaths were those aged 50 and older. But that's only around 35% of the population. So even though the majority of cases were reported in those under the age of 50, we're seeing higher death rate in terms of those over the age of 50. And so why did we see this increase in deaths in long-term care facilities? Age could be a factor. What other factors could play a role?
Should I add to that? Okay.
Absolutely. Yes. Thank you.
I always, with my students, because that's essentially what health geography is that there's this biological component of, sure, based on your age, how well can your body defend itself from infection? If it has an infection, how well can it keep up your other biological functions, to prevent severe illness or prevent death. And then there's always a place component, or a structural component, or we might say contextual component of where physically are you. And there's things about long-term care facilities that make isolation, for example, really difficult. People who live in long-term care facilities, number one, there's a finite amount of space. People are likely to have, share rooms, so have a roommate who's in close proximity to them all the time. They may be reliant on staff to help them with feeding, with changing their clothes, with taking them to the bathroom. So there's really, constant interaction among, the people that sort of make up that facility. So, unfortunately, what we've seen is that with COVID-19, and this might also apply to correctional facilities and other areas where people are in constant close proximity, that once it is in, it's very difficult to keep it from spreading. So if we really wanted to figure out what the additive effect of being an older person specifically in a long-term care facility was, we might compare, over 75 individuals over the age of 75 outside of correctional facilities to those inside of correctional facilities, and then looked at how big that difference was specifically.
So like a comparative analysis.
Mm-hmm. So one of the groups who has really been looking closely at this is the AARP folks, of course, which are the union of retired people. And they've actually been talking about this issue since long before the pandemic. And they point to to some real problems in the long-term care facility industry. One of the things that was really quite striking to me, the turnover rate for employees is extremely high. In some long-term care facilities, the rate is as high as 300%, which means that many of the people who work there are only there for a couple of months. And that leads me to believe that they simply weren't trained and weren't prepared for this. I heard one epidemiologist describe it as a tornado in a trailer park, which unfortunately might be pretty accurate for that. The other thing that AARP noticed was that in the early stages of the pandemic, you may remember back when nobody really had enough of the PPE, and the federal government sort of scooped it up as quickly as they could and started distributing it to hospitals and other healthcare facilities. But AARP is making the point that many of the nursing homes were left out of that, and they didn't get the equipment that they needed early on in the pandemic, and that's when the thing really started to hit them. So I think this is a classic example of we just weren't ready for it. We had no idea what was going to happen, and so now we do know, and then we have to change the way that we do things, at least in terms of the long-term care facilities and probably correctional facilities as well.
Mm-hmm. Yes, and I know that they're looking also in terms of those long-term care facilities that had a bit of a success story in terms of their numbers, and seeing what they did right in terms of that success story, and the training of their staff and the support of their staff, along with building trust and mitigating measures, being able to do that isolation if at all possible as soon as possible, and identifying those infections early on.
Great point there, and some good policy things for people to think about, I think.
Mm-hmm.
Any comments about that? Go ahead.
Oh, I would agree that at these types of facilities, the investment of staff members in the processes and protocols is just really crucial, because they are the mobile component of what's going in and out of these facilities. And, as I think one of my slides reflected, individuals who work here, either in they may work as maintenance workers, they may work as nurses assistants, and, they may live in communities or in neighborhoods that, have higher infection rates because, they're more socioeconomically disadvantaged. And so it's really like thinking about, yes, it's a facility, but it's part of a bigger constellation of networks and flows in and out of that facility. And with staff being the main mobile component, I think it's really important to try to gain trust and buy-in into the protocols and routine testing and everything like that.
Great point. Okay, we have one other question to share with you, and then we'll take some questions from viewers. Tom, could you show us the question number 3? So the question, I think, is here: what are their correlations with states? Because some states had lower mortality rates than others, and some had higher. So are there correlates of mortality as we look from one state to another? So before we look at some slides here, let me just make you aware, this is about as high level as you can get in terms of analysis. And we aren't looking at specific communities within those states. We're looking at very broad geographic areas. So Tom, if you could show us the first slide. This slide shows mortality rate by state, and the highest mortality, so that's deaths per 100,000, was New Jersey with 270, Hawaii at the bottom with 32. Utah, you could argue, fared pretty well with 63 deaths per 100,000. The interesting thing here is that it's a pretty straight line. So it's a function of something, and we can start to ferret out, I believe, what it's a function of from one state to another. Tom, if you could show us the next slide, please. If you remove the long-term care facility deaths, you still get a straight line. Some of the states change places. Vermont is now the lowest. New Jersey, unfortunately for them, stayed at the highest. So I think the question becomes, what is it here about certain states that gave them higher rates of mortality relative to some of the other states? And before I show you some of the correlates, keep in mind what Dr. Lewis said a few minutes ago about this discombobulation that was going on, because I think that may be a part of the story as well. Tom, if you could show us that last slide, please. These are things that we've already started to identify as correlates of mortality. If it is a red correlate here, that means that it's a negative correlation. If it's a black correlate, that means that it's a positive correlation. So some of the things we see from state to state as we look at mortality rates, one thing that's just absolutely striking is that as the higher the high school graduation rate goes up, the mortality rate goes down. That's just absolutely stunning to me. And that speaks toward the real importance of education and what we do here. Similarly, and this will relate to some of the things Dr. Lewis has already shared with us, as the poverty rate goes up in states, so does the mortality rate. As the African American and Black rate goes up, again, that's according to the nomenclature of the Census Bureau, so does the poverty rate. As the percentage of people who are Caucasian goes up, the mortality rate seems to go down per states. And of course, here you've got your socioeconomic status. As you have poorer states, you have a higher mortality rate. Bachelor's degrees seem to be important, but not as important as the high school graduation rate. And then you have issues of healthcare. So the quality of healthcare is measured by certain metrics. The health of people, obesity was a major determinant here. As states with high levels of obesity increase, so does the mortality rate, and so on. Two things that I found interesting as you look at correlates, it didn't seem to matter as much what the population density was. So you can see next to the bottom here, people per square mile, the correlation here is still 23%, but that's pretty close to not really being a correlation, because you get close to 20%, that sort of goes towards sort of randomness, if you will, with correlation coefficients. And then the other one, politics didn't seem at this high level to really make that much difference. We just looked at the percentage of people in that state who voted a particular way, and it correlated, but really not much more than randomness. So I think the story here, and maybe we can talk about this, there seems to be an underclass in this country that is largely uneducated, largely Black and Hispanic, and they don't have access to healthcare. They have poor income, low income, and their health in general may already be bad, making them susceptible to this kind of a problem in the future. I have no idea what the policy implications are here, but it seems to be that this is the story that's emerging from the mortality rates.
So I completely agree that all of those factors are important. I think how you laid out, specifically like New Jersey being in the #1 position, and I'm originally from upstate New York myself, and I think there's distinctions about that part of the country, but it brings in the timeline element that Annette mentioned as well, because I think New Jersey has the unfortunate position of, there's a high degree of inequality in New Jersey. I mean, you have your, like Bergen County, places like that, certain communities like you may see profiled, for example, on like Real Housewives of New Jersey. There's that. And then there is a really large socioeconomically, deprived population that's largely Latino or racial minority in cities like Jersey City, Bayonne, Paterson, places like that. And they unfortunately were among the first in the country to be hit with the pandemic. So I think you have, a high degree of disadvantage coupled with being hit during the early days. This would be similar in Louisiana, which got, was hit very hard very early on, where a response hasn't, yet, there's not been as much time to coordinate a response. And so I think that's why you see, such high levels in those sorts of places.
So one of the things that I have seen in this pandemic that I think is just absolutely fascinating is this whole notion of essential workers. And when most people hear about that, they're thinking, of course, of doctors and nurses and the people in the hospital, which absolutely are essential workers. But this pandemic seems to have revealed that there's a whole nother group of essential workers they're in the grocery stores, and they're at the drive-up window of the fast food restaurant. And many of these people, because of their socioeconomic status and the jobs that they have, they weren't able to work remotely. They really were forced to go to work, even though in some cases we now believe it probably wasn't safe for them to do that.
I would just add that one of particularly in Utah, but across all states, we've really seen, fairly severe outbreaks in workplaces associated with certain industries. So, particularly manufacturing and food processing, things where people need to be working in close proximity on, say, an assembly line. In some cases, those individuals may also, live on premises in high density housing, where arrangements have been made for them to do that. They may be taking transportation together to the work site. And yeah, I think all of those, and though they are essential. I mean, those are industries we rely on day to day to be fed, to keep ticking along, and those
The running of society.
Exactly, yes, and those are places that, as much as healthcare, and they may, in contrast to healthcare facilities and healthcare workers, they may not necessarily, sometimes in some cases don't speak English as the first language. They don't have access to the education and the knowledge and the skill and the resources to, adequately protect themselves, in those kinds of work sites.
Would also be interesting to see a family, because you had mentioned family dynamics and family correlates along with this as well, in terms of these areas, based on the states.
Definitely. Yeah, no, definitely.
Did you observe any evidence that maybe there was a messaging problem relative to language early on in the pandemic? I heard reports that we were having trouble getting information, for example, into the Latinx community, because we weren't able to, maybe we didn't think to use their own language to try to tell them things, or we just had trouble connecting with them.
Yeah, I don't know. I wouldn't say this is necessarily the case for Utah or any specific state, but I mean, there's always a challenge with messaging, kind of when there's, when English is kind of considered the official language, and then other languages, are secondary, and in public health, we should really begin to be thinking more in simultaneous terms, that multiple communities need to be reached simultaneously, rather than kind of, dealing with what maybe consciously or not consciously imagine to sort of be like a core, and then going to, different groups around it. Because we all, regardless of what group you're a part of, you're interacting, at the grocery store, or at, on the bus, or on tracks, or so, it's really, these groups are not discrete entities, so they all need to be reached at the same time.
Okay, so that is a couple of examples of the kinds of questions that epidemiologists will be looking at. Again, this is very early in the process, so it's a very high level sort of information. We do have some questions now that have come in from people listening, and we'll turn to Tom to ask those questions, and any of the participants can respond.
Okay, so I think the stream chat can hear me. I might be only coming in on one ear, so I'm probably gonna have to fix that so I don't freak you out. So let me just fix that real quick. All right, cool. So first question we had come up is, how do you think the variants will affect cases in Utah?
I can really just give purely not a prediction, but just what I see based on the data at this point in Utah. but I think Utah has done a really good job on vaccination efforts. And what you see with Utah's incidence rate is that sort of for the past 4 weeks or so, it's been pretty constant. And actually during this past week, we've seen it start to go down again a little bit more. So this is in contrast to other states where in contrast to other states where they've actually seen slight increases, which suggests that among uninfected people, the variants are driving a somewhat higher infection rate. Or in Canada, where they're having, a complete fourth wave now, and a surge. And I think this is, likely due to slower vaccination rates there compared to here. So I think the outlook at the moment looks good for Utah. I think by pushing fast on vaccination as fast as possible, we're hopefully going to escape some of the impact of the variants. And you'll also notice that the variants seem to kind of, as would be expected, kind of move from higher concentration at ports of entry areas of the country, New York, California, Florida, and it takes a little while for them to make their way into states like Utah. So I think the prognosis is optimistic at this point. Would be my impression.
Another piece of good news is that really none of the variants have completely escaped the vaccinations so far. So, and when you start in the 90s with efficacy, you have a little bit of room to give there. So we have highly efficacious vaccines. And I think you're right. The key is just keep giving them and get that rate as high as possible.
Okay. Annette, do you have anything to add there? Or?
No, I was just going to mention about the vaccines. Yeah.
Perfect. So to go to the next question then, and this might be a quick one, but do you project that we'll be wearing masks for the remainder of the year and into next year? Or do you feel we will? Without getting into opinion, of course.
Well, we don't know. I mean, the answer is we don't know. As soon as the numbers get low enough, and as soon as everybody who wants a vaccine has had it, I think we'll start to see a loosening of that. I mean, we no longer have a statewide mask mandate, but I think people are wise to continue when they're in large groups or things like that to keep wearing their mask. I think what will happen is we'll start to feel more and more comfortable as those numbers decline. And it's really going to be up to individual people to start, I think, determining, when it's time to quit wearing their mask. And it's about comfort, I think, more than anything else now. But we still have to keep vaccinating. We're not quite to the point where we need to get.
And I would just add that in a context of, kind of incomplete information at this point, it's yet to be seen kind of how long the efficacy of a vaccine is going to last from season to season, or the degree to which, there are so-called breakthrough cases where somebody's getting infected despite having a vaccine, and how often that's happening with variants versus, the original. And since we don't have hard and fast answers to all of that, the mask, in addition to getting vaccinated, the mask is your best tool for both protecting yourself and kind of, making your contribution to the protection of others when we don't have all the answers. And you can meter out those decisions based on where you are, and particularly if it is a congregate setting and you have to be in close proximity to a lot of people, it's in your interest and the interest of others.
Yeah, based on situational kind of events and effects, I could see, and determining within your comfort zone, along with what is best for everyone around, and keep watching the data and keep watching information that keeps coming out.
Okay. Thank you for those answers. They were awesome. The next question, I think, ties into the, not this previous question, but the one right before, but it's, do you expect a fourth wave? And if so, are we prepared? I know you mentioned earlier that the vaccination rate is probably helping us, but.
variants will play a big role, and the types of variants.
Yeah, and it's gonna, I mean, the difference, as it has throughout the pandemic in North America is it's gonna vary somewhat on jurisdiction. And yeah, in jurisdiction specifically in terms of the decisions that they're making about, or their capabilities in terms of vaccination vis-a-vis decisions about opening things. And again, I would use like the Canadian example, like vaccine rollout has not been as fast. There's no vaccines that are produced, locally in Canada. So reliance on imports and slower overall rate, coupled with opening in provinces like Ontario, you can see, what the result has been. So, all of those factors are gonna play a part. I think Utah is doing a good job right now. If we continue, vaccinating at this pace, my hope is that we'll be better off than, some jurisdictions. And that's partially to do with, where those jurisdictions are, and is there a big city? Is there a major airport? How close together do people live? So again, it's complicated. There's not, right. All of these answers are complicated, right? So,
One thing about a possible fourth wave, don't forget we have vaccinated older people really heavily. And so there is hope, I think, that if there is a fourth wave, the mortality rate might not be quite as bad.
And with that, potentially the hospitalization rate.
Hospitality rate should be lower.
Yeah, I've definitely turned mine down. So,
okay.
All right. So to tie to this is actually kind of on for a lot of the students here. Many of us are or will become employees of LTC facilities, hospitals, clinics. How can we best prevent the spread of COVID and infectious disease within our own work/clinical communities?
We have the expert here to tell you that.
Is that me?
One of us.
I would say you're right. I think the biggest thing is that, and this is not intended to sound like soapboxy or moralistic or something, but it's not just at the work while you're doing your work or at the workplace when the prevention occurs. Like I've heard about nurses, getting sick from each other because they had lunch together. And, yes, they weren't like delivering care at that point in time, but, they amongst, their own communities and just doing something casual, is when they ended up becoming infected. Knowing that we can infect others and not yet know that we're sick, it's important to be mindful kind of that danger and those responsibilities, I think, at all, unfortunately, at all times of the day and in all contexts, that you can't let the guard down.
Yeah, I know in some long-term care facilities, they've seen that the way that the people who are working there was outside of the care facility, they could bring it in. It wasn't necessarily they were getting it from within, it was that they were transmitting it because of outside of that work. And so I think it's just being consistent across.
A similar thing was happening in the schools. I mean, Dr. Lewis's work showed that schools were taking great precautions and there wasn't much transmission at the school. But then you would see the kids congregating out on the playground after school or all getting on the same car to go home or something like that. And that was just a terrible idea. So I think it's a great point when you're going to be working in a place like that. Take the precautions there, but also be aware of the times when you're not there.
Smart. All right, so we are at the hour, so I'm going to speed run 2 questions really quick, if that's okay with y'all, and then we'll wrap it up. All right, so this one is actually interesting to me as well. So is there a correlation between blood types and infection?
I'm unfortunately not versed in the science on that question specifically, so I will hold back on answering that one.
Okay.
I haven't seen any convincing evidence that there is. There was some talk about that early in the pandemic, but I'm not sure that it panned out. So at this point, I have not seen any convincing evidence that that is true, nor can I really imagine a reason why it would be true.
Right.
There may be specific genetic backgrounds that are more predisposed, but I haven't seen that kind of evidence yet.
Yeah, neither have I. I mean, I've seen some studies and data, but it's not a lot of over time. It was early on. Yeah.
Okay, perfect. So this next one, why have people reacted differently to vaccinations? Is it tied to their age or differences in immunity? How is that affecting it?
That's complex. Yes.
I mean, yeah, I would just give right there. I mean, I have heard reports of that. Like the reaction is stronger, potentially in young to midlife individuals because the immune system at that age is more reactive. I would say overall, it's not something to fear or to be fearful of. In fact, that means that the vaccine is, your immune system is responding to the vaccine and doing what it needs to develop the protection against the virus. So, I would encourage, there's very few reports of reactions, if at all, that can be connected directly to the vaccine that are, putting people in the hospital or doing grave harm to them.
One thing I have talked about with some of my students, I mean, there's a lot of people who were infected by the virus and never knew that. So a lot of asymptomatic infections. And if somebody gets their vaccine having already been infected, they may go straight to something very similar to a secondary immune response, which can sometimes be quite a bit stronger than the primary immune response. And so they'll still need a second shot, but it may be the case that for some of these people, their first shot is really acting as a booster shot for them.
Mm-hmm. Yeah, their immune system has already kind of been taught the initial, yeah. And then that way it can react a little bit quicker. Mm-hmm.
Yeah.
Makes sense.
So one person told me that it was really just because millennials complain more. I don't think that's necessarily correct,
Hey.
but I was told that.
Hey, I resemble that remark as your producer, sir. All right, we'll go just quick one and then maybe one final one for some hope at the end of it. So this is, in the areas that were hit first, what were some of the commonalities noticed? Coastal demographics, tourism, that type of stuff?
Yeah, I think that is really interesting to think about. And there's certain places where certain constellations of factors that would be risk factors all tend to coincide. So I had mentioned major airports. So what's the initial entree of the infection into the place? And in places like New York and New Jersey, those tend to also be very densely populated places. Same with Southern California. There was talk about sort of Mardi Gras being what we'd call an antecedent event to the huge spike that happened in New Orleans. So I think population density and kind of large inflows and outflows both contribute. In Utah, where we saw the first cases, and kind of the first subsequent mini spike was actually Summit County, which is where Park City and most of the large ski resorts are. So that's presumably potentially where the kind of the main introduction and person-to-person transmission were taking place in Utah. Obviously, then once it got into Salt Lake City and the Salt Lake Valley, then sort of it took its course after that. But I think that's a really interesting question to think about, where initial spread happens before kind of getting into the main population.
All right, and this final one, just to wrap things up on what I consider a high note, has the search for a vaccine led to any other research breakthroughs?
So So the mRNA platform is a huge advance, I think, in vaccinology. And you're already seeing new vaccines for places that they really weren't possible. I just saw they've already started some clinical trials of a possible vaccine for HIV, which for many of us we thought would never happen. So I think this is a paradigm shift in the terms of vaccinology. The other thing that'll happen now is that even if the variants become a problem, it's an overnight thing to change the vaccine. You just change the sequence of the messenger RNA and you've got the variant in there for people to get their booster shot. I mean, you'll still have to do the clinical trials, but I think because of these new vaccines, we have seen a major shift in the way that people are protected from diseases in the future.
Right, seeing how the efficacy of this vaccine works for this instance, and then how easily it can be adapted to specific things. Yeah, I've even read with MS as well, some other areas that they're looking at in terms of research. So, yes, definitely a high note.
It's an amazing time. Well, thank you so much for this amazing conversation. This has been really, really great. Annette, thank you for joining us. You've been very helpful in helping to put this together. Dr. Lewis, thank you for taking time out of your busy day. We can only imagine all of the things you're doing right now and all of the juggling you're doing to keep things going. So we thank you very much. And also, Tom, thank you for producing this for us and doing such a great job of making this presentation. So have a good day, and thanks for everybody for joining us.
Yes, thank you all.
Thank you.